Paul Seegert from PCS Advisors joins us from time to time to catch us up on what's going on, what to look out for, and potentially how to deal with it. How you doing, Paul? Thanks for joining me.
Doing great. How are you?
Well, I'm good. I read about some things I didn't have on my radar, and I got a message from you that some things that are expiring, some of the COVID-related perks in terms of subsidies, for companies, for individuals, could be a problem. Medicaid expansion for those who may have, fallen into some Medicaid that maybe otherwise pre-COVID they wouldn't have. That might go away. Another piece about how individual pharmaceutical prices are spiraling as compared to, group insured people. A lot of things really threaten the healthcare pocketbook of our listeners, don't they?
Absolutely. And it never seems to get solved. If you're looking to Washington to solve this problem, it will only get worse.
Yeah, so let's talk about those premium hikes that could result from expiration of some COVID-related perks and, accommodations that went on.
So you have a couple things going on there that are going to have a big impact on the system. One is that the states have not been auditing continued eligibility for Medicaid. So, and that's part of the public health emergency, which some people believe is why the public health emergency continues to get extended, because as soon as they stop that, there's some funding that the states are getting that'll stop, and no doubt when that funding stops, they're going to start very quickly to audit their Medicaid enrollment, because their portion, what the states fund, is always a very large budgetary item for states. So
it's the largest part in Missouri. Yeah, I think it's 2/3 of the budget. Yeah. I recall. Yeah, it's huge.
Massive. Yeah, and we grew. We went from 27 to 36 million roughly in folks that were enrolled in these programs from 2020 to 2022.
And, in Missouri, Paul, Medicaid expansion has been a contentious issue. A constitutional amendment a year or two ago, finally brought it in, but it really hadn't been funded until now. And so that's going to put fuel on the fire of the regulators to really scrutinize the eligibility rolls. That's what I'm hearing you say, right? And it could be worse in those states with new expansion.
Yes. So they're going to start to do that, and that could be 14.4 million people could lose that coverage if the public health emergency ends, which it will end at some point. And then you have other subsidies that were part of the rescue packages for COVID that expanded subsidies for people that went to the exchanges. We said we removed some of the rules about, 4X the federal poverty line as an example. Nobody was going to have to spend more than 8.5% of their income. So you could have a 60-year-old couple making north of $200,000 a year that went to the exchanges and got subsidy. That also is that when they pass that, it was set to sunset at the end of this year, and there's nothing so far that will change that.
Was that supposed to be a part of Biden's budget buster $5-6 trillion deal? I mean, was that going to be extended, or maybe
hope was that they would add to that and lengthen it? Exactly right.
Okay. So that's going to go away. What else is out there for premium shock?
Well, and then you're going to have just the normal increase that we always deal with, which will be bigger in my prediction, because you said something very good at the start of this, which was healthcare inflation is always bigger than the rest of the market, the rest of the economy. CPI and healthcare inflation, it usually runs 2 to 2.5 times higher. Mm-hmm. And then, so we're running at about 12%. Officially in increases in costs in healthcare, and that you don't need to give insurers much of a reason to dole out increases, and that is a very good one, and that is expected to to last for a couple of years. That elevated level of inflation in healthcare, it usually runs half that. So,
Paul, let me offer you something that I just read about the other day. That it's not necessarily going to hit patients, whether they're well visit type of visits or whether it's sick visit patients. But I just read the other day, HCA and other hospital organizations, because of the tremendous wage inflation that we underwent. And I can tell you, I have personal experience with that.
Yep.
Crazy prices to get, traveling nurses and so forth during the pandemic. Well, Just crazy. And most of the insurance company contracts that hospitals have only allow a 4 or 5% kicker at most.
Yeah.
And HCA and others are looking for 11%. They're being denied, and they're being laughed at by employer groups and cost containment groups, and certainly insurance companies are going to blow them off. So all I can conclude is that's going to mean less service, a diminished patient experience, potentially some diminishment in quality of services, because I mean the hospital's got to make it up somewhere. That right? They can't keep up with those wage demands.
Well, exactly right. You have we're headed right into the face of a shortage of 1 million nurses. And we're not going to be able to solve that by, and there's lots of reasons that contribute to that. You know some of them better than me, but not providing enough reimbursement to hospitals isn't going to fix it.
Yeah,
I know that for sure.
Yeah.
And another issue that we're walking into is this whole idea that these people that maybe get pushed from Medicaid to then going to the exchange to get a plan, it's not just that they're now going to be responsible for some share of premium. They also then are going to have a plan where they are responsible for a share of cost when they seek services. And that's kind of an untold part of the story, too. You're going to have folks that now go from having all of their care subsidized, premium and out-of-pocket costs, to having a $7,000 max out-of-pocket.
Ooh.
That's a big change.
Wow. And that has ripple effects on the system as well, because docs and hospitals that render care because of moral and legal and ethical binds are, bound. They're bound to do that morally, ethically, and legally in some cases, depending on where the interaction occurs. A lot of that results in bad debt. And again, someone has to pay that. So that may raise prices on those that have individual plans and others. Or again, quality suffers, no?
Absolutely. We've turned hospitals and we've turned providers into collectors, or they have to outsource it to a collections firm. One of the ways that we're able to interact more positively with providers and lower cost in the system for our clients is to go to providers and say, look, whether it be a hospital or outpatient surgery center or some other type of provider, to be able to go to them and say, the system today isn't working that well for you. They're stringing you out 60 to 90 days to get paid, let's say, and that's in a pretty good case. And then you're chasing a member for $7,000. What if we paid you in full within 5 days? And in full means in full. You're not chasing the member for anything because they have no share of cost. Would that be attractive to you? And could we work out an arrangement that works for everybody? And they're very willing to work with us in that way.
Yeah, well, that's it. Well, how do you get the money from the patient? That's what I want to know.
We control the health plan.
Okay, so
when the plan's running efficiently, you don't have to chase the pay.
And I know you do some. And this is something I want to continue to advocate. And when we talk, I know we touch on this in one way or another. It seems like every time we chat, there is a better way to deliver healthcare in this nation, and that is to restore both the professional transaction as well as the financial transaction to as much of a direct one between the provider and the recipient. Right? And carve out that insurance middleman churn, whatever you want to call it, that eats up tons and tons of healthcare dollars and provides absolutely no care, but a lot of profits for the insurance companies. Right? Yeah,
it's just a system that is so full of waste. And it's funny because I have a book that sits on my desk, and it always reminds me of there's like so many discussions or arguments, whatever you want to call it, there's so many misinformed opinions out there that they just don't understand how our payment model works. We don't have a free market. We do in certain little pockets, and they demonstrate some success that we can follow in doing what you just described. If you look at what happened to the cost of LASIK surgery over the last 10 years, what has happened to the cost of cosmetic procedures where the insurance payment model is out of it, and you have direct relationships and typically cash paying relationships between a consumer and a provider, you have quality that goes up and cost that goes down, like you do in every other industry. But somehow in this industry, we've created inefficiency on purpose that does benefit. The only clear winners from the last 12 years of our Affordable Care Act experience are insurers. I mean, they've done incredibly well. It's just appalling how well.
And so have the pharmacy benefit companies too, right? Those PBMs, as they're called. Now, some good news, maybe at least rhetorically. The other day, a story out that they took a beating, and this is pretty much, I think, a bipartisan sentiment in some Senate hearings. Expert witnesses were calling for strong consumer protection. There's a lot of stuff that goes on there that hurts people. Do you see any movement in congressional, either statutory or regulatory, that can relieve and distribute some of the money that goes up again into these black boxes that are called pharmacy benefit managers, and come back to the people paying the bills?
I don't have tons of optimism there, at least from the acts of Congress and the moves of Congress. For instance, Affordable Insulin Now Act that's moving through Congress. What a red herring. I mean, it provides the opportunity to trot out onto the steps of the Capitol and say insulin's only going to cost $35, like in our peer countries. But when you read down into the fine wording of the bill, they're just saying PBMs and insurers, you can continue to rape and pillage the system, but your copay that you require of the consumer cannot be more than $35. So a box of Humalog pens, the most commonly prescribed insulin in America right now from Eli Lilly, is still going to cost $550 in most health plans to the plan. So it's actually going to have the reverse effect of what we all want. Yeah, the consumer feels good at the moment of purchase that their copay is now only $35, even though north of 75% of people that was already true. They're going to push a little bit more cost into the insurance plan, which will give the insurer another reason to jack up the increase at renewal, and the ripple effect continues.
Or the employer extracts more in terms of cost sharing, right? So that's right. One way or another, someone's got to pay that bill. Yeah.
Exactly right. And my hope is with employers, and I'm when the conversation gets to this moment, I'm very optimistic, and it surprises people. But there are employers fixing this every day, and they are going to lead us out of this mess because they're getting to a point in terms of cost that they can't ignore it any longer, and they'll look at their plan and say, I'm going to carve this piece out, this pharmacy benefit management. And there's 300 of them in this country. Let's let them compete for my business. And there are a handful now that have come forward and said, we'll do it in the old business model. We'll only charge a per script fee for this service. And that is the future, I believe, of where they go out and competitively shop some of these subsidiary cost drivers in their plan and really benefit their company, but also benefit their employees and their families.
So that's a real pearl for those of you that are listening carefully and either are responsible, in some way as part of an HR administration or, in the C-suite, thinking about how in the world to make ends meet and still provide these benefits for your employees. If you do, there is a better way. And Paul Seegert also has these great ideas that I don't think they're not shared, because there is really this insurance, the medical, I'd call it the insurance industrial complex, right? Because they're all in collusion.
That's right.
And it doesn't really benefit too many people that really need the benefits, meaning both the medical benefits and some financial relief from what is a skyrocketing health insurance spiral. So Paul Seegert with PCS Advisors, always appreciate your insight into this. Let's stay in touch as the election season heats up, the various plans come out, and we'll see if there's anything that is optimistic. But in the meantime, I think people should really be aware that they need to do some shopping. They need to ask a lot of questions, and maybe talk to 2 or 3 or 4 different insurance advisors before you land with one. That's what I'd recommend. So
I totally agree, Dr. Tobler. I hope to come back and talk to you again.
All right. Hey, thanks, Paul. Appreciate it. There is Paul Seegert.